Good morning, everybody. This is a special day for a number of different reasons. The most important is I think we all like free things. I'm getting free things from Glenn Keating today. So it makes me very happy. So you'll see where that happens. But yeah, that's one of my favorite, one of my highlights of the day. And we'll talk about that more. But today, our bigger plans and the more important plans are we're going to do some debriefing. So everyone's done the airway thing. Thank you guys so much for your patience. I know that there was a lot there, and the individualized training is also a little stressful. So we're going to debrief that a little bit. Clinical updates, I don't think I have much for today, but then I'm going to pass it over to Chief Burgess to give us any other operational updates we need for right now. But more than anything else, I am really excited that the airway stuff is done for a couple different reasons. But most importantly, just because it was a lot of work. And actually, though, when all is said and done, I think it was strong, worthwhile work. So you're going to see it come back again. The big investment of time and energy from our clinical team was really to design the mannequin and the setup for you guys, getting all the cameras in the right place and all that kind of stuff, and as well as making sure that the mannequin was difficult enough so that it wasn't just like a quick shot like we have with our task trainers. Most of our task trainers are really, really easy. They don't really give you any real challenge. It was nice to see that we pushed you a little bit more with this specific airway. And our goal in the future is, well, hopefully we can leverage this to push us towards learning different other skills at the same time that we're using difficult airway mannequins, right? So as you can see already, as we're getting closer and closer to the release of our fiber optic devices, that would be something that we could think of including into this type of simulation so that you guys get an experience of playing with all the toys simultaneously. Just as a source of the debrief, I mean, I think we all kind of remember what the directions were. You're a primary provider. You have an EMT who's already on the scene. Do what you need to do for the patient. You are the lead. And then we gave you an outline of what was actually happening. It was a 911 call. The guy fell down. He's making incomprehensible sounds. Painful stimuli was all he had. He opens his eyes and withdraws a little bit. BLS response hit there first. You have 20 minutes to the closest hospital, and his SATs are junk, and he is not looking so sharp, and things get started. And after things get started, things decompensate. So if you actually were successful in the work that you were doing initially with airway management, things went south, and your EMT partner decides to pull the tube on you. Which it was great to watch everyone's faces when you heard that, because I felt the same way. It's always painful for that to occur, and at that point you end up facing a more difficult airway process, and so that made it even a little more challenging. So in the vein of a debrief, to talk this through, I do want to touch base on some of the concepts that we talked about in the debrief when you had over there, and so we're going to revisit some stuff here. But I think the biggest concept here, and I think all of us know what our focus was, is we really wanted to focus on these four key training skills: bag valve mask, ETI, backup, and ventilations. And you probably noticed that one of the things that I was trying to push pretty heavily, and you probably know this from our debriefs and everything like that from this experience, was ventilations. I'm a firm believer that if you can bag someone, they will live, right? I don't have to be able to do an ETI. I don't even have to be able to do a backup airway, but if I can ventilate them, they will probably live. And I will get back a functional brain. And that is my whole goal. I want people to live with a functional brain, right? And the cool part of the way we set this whole thing up is that you got detailed feedback. You got feedback of your positioning in space, so you can see what you were doing with yourself in space. But the more important thing is two different things. One, the internal view, so you could actually see what you're doing with your tube and with your laryngoscope, which is something that we probably haven't had feedback on. And most importantly, this lateral view. I think for some of you, I actually really took some time to point out the lateral view, because the lateral view, when you're looking from the side, you could really see if somebody's going to get it or not, just because of how they position themselves. And frankly, positioning was a big part of this training. What would you do if you're on the floor, right? And so there was actually a number of different approaches, which I thought was really exciting. We saw the lay down approach that we have all the way over here. We saw the knees down approach, and frankly, it's getting harder and harder for me just to do the knees down approach. But we saw a number of people do the side, hey, I'm really cool, I'm going to do it on the side approach, which I think is pretty awesome too. But I was most impressed by what I would refer to as the crisscross applesauce intubation. Picture from Glenn Keating, and this is where I get my coffee. He dared me to do this. Of course, I'm going to put it in there. And I actually even tried it. I thought this was really a great approach to doing this, where you're crisscrossing your legs, and when you do this, as you just lean forward from your torso, it pushes all the soft tissue completely out of your way. And it was unbelievably one of the best views I've had. And I'm actually a lie on my belly type of guy. I've always done it that way. I like it that way because I leverage my elbow against the ground. But this gave me actually even better views. So crisscross applesauce. My kids like it. So, hey, why not? I don't even know. I mean, I know they're the band Crisscross, but hey, it was way before my time. Anyway, so
mid-90s.
After my time, I guess. I was an adult by then. So when we think about the different steps, one of the first steps I talked about, and which was one of the most challenging because it was a simulated environment, was the bag valve mask. The thing is, I think we've all gotten stuck in the trap. When you walk in the room, somebody's going to be bagging, and they're going to do a poor man's job. And it's going to be bad, and it's going to be something you need to fix. And not only do you need to fix it, you need to do a good job with it, right? So this mannequin that we have right now is a difficult bag and a difficult intubation. So again, this was the introduction of the mannequin. So I didn't expect you guys to hit this. But in the future, what you're going to note is one of my specific outcome variables is how well do you bag, right? Because this is going to be one of our priorities. We want to make sure everyone has a good seal and that everyone can ventilate well. Doesn't mean you have to do it on your own, right? Two-handed technique is great, but the real big issue is this. When we think about the time to desaturation that we experience with our patients, a normal adult is right here. Beautiful, you get 100%. It gives you a lot of time before you get full desaturation. All of our patients are not that. Our patients automatically, if you're thinking about intubation, are generally right here. They're the moderately ill individual, if they're like a normal size person. None of our patients are normal size. They're all high BMIs and things like that. So what you're looking at is this line right here. This painful line that people completely decompensate very, very quickly. And you can see that it says 2 minutes. But again, this is from a fully saturated individual in normal health, not someone who's sick and decompensating, right? So we know that more often than not, we really don't have very much time. And so one of the key aspects before we even get into intubation is ventilate the junk out of them so that you can maximize your recruitment of all of your alveoli and supersaturate as much as you possibly can. So it brings us back to the concept. For airway management, ventilations are the CPR of airway management. I just said airway management twice. That didn't work out well. But okay, you guys get the point. It's on the board here. Hypoxia and rate are the key things we're going to hit. And of course, the key principles, I think we all talked about this, about hand positioning, oropharyngeal airway placement, ventilation rates, all that kind of stuff. And really think about what defines people who are difficult bags, right? Make sure you have the mask seal is good and all the different things that are associated with mask seal. Now, I don't know about you guys. I'm not a mnemonic guy. This is Moans here. I'm much more of I get the gestalt. I get the idea, and then I put all the pieces together and make sure I understand the pieces. And so for me, I have a hard time memorizing these. You don't have to memorize this. This is just a kind of a teaching tool to remind ourselves. Like keep the teeth in, right? Things like that. Like keep the teeth in when you're bagging, right? And put all those things into place. Now, when we think about our steps of bagging, again, notice I'm pushing bag valve mask hard here. When we're thinking about our steps, consider doing clearing everything out, using an oropharyngeal airway, position the neck appropriately, and then use the do a per 2-person team so you know you have a good seal and that you can evaluate yourself for leaks and have somebody else evaluate you. When we talk about laryngoscopy, it becomes a little more complicated, right? So we start talking about things like the Lemon Law. If you, again, like mnemonics, mine is much more, okay, is this person going to be easy? Can I look at them and kind of make some decisions? Obviously, look externally, evaluate the 3-3-2 rule, right? So 3-3-2 rule, and Malin putty, if they're able to be awake and alert, that they can open up their mouth and show you their oropharynx. That a Malin putty does not apply to any of our patients, right? Normally, they're completely out of whack. Actually, in truth, you can probably ask a couple people before you tube them, hey, open your mouth for me, right? Obstructions in neck mobility are other things. Neck mobility got me in the most trouble when I had to recently correct somebody. There was a patient who had who was syndromic and had a cervical spine fusion with a plate. I couldn't bend her neck at all. I got nothing. And of course, she was syndromic, so she had a short chin. You can imagine the trouble I was having. And in the end, we had to crike her. Because in the end, this is what you want to do. You want to line everything up. And I think we spent a lot of time when we were talking and debriefing about how you line things up. Line up the three key axes of the laryngeal to the pharyngeal and the oral, and that's going to give you your best view. And as you push away, push up and out, and that's going to give you that view so that you can see everything and align that direction as best you possibly can. Sorry, I forgot about that. And so that's going to be that. And so even when you're on the floor, same basic concepts. So when we look at people who are on the floor, one of the things I love about the lateral view, and we talked about this a little bit during our debriefs, is it tells you everything. So if I'm making arrows from the lateral view, looking at what they're seeing from their laryngoscope and where the tracheal is, I can actually have an idea already. Probably not seeing what he needs to see yet, right? But also, this particular intubator is probably not done the push out yet. So they have not completed their movement yet. So it kind of gives you an idea. The last thing we touched base on this on a previous Zoom meeting, and I don't want to hammer it again today, is peri-intubation crisis and the things that we can do to put everything in place. So when all is said and done, this is what we experienced. We experienced a difficult airway simulation where you got to do an ETI. You were successful or failed, it doesn't matter. Because in the end, your goal was to overall succeed by ventilating the patient. And we all did that. But the whole focus of this whole thing for me was really focusing on these ventilation assessments. And that's what you're going to be gauged on in the future too, okay? So the core concepts again, BLS skills are critical for success. I think we say this about for cardiac arrest too, right? Making sure our BLS skills are tight and we know what we're doing with our bagging is key to making these people survive. Make sure ventilations are the CPR of airway management. So what are we going to have in the future? In the future, where we're going is fiber optics. So coming up here soon, you guys are going to get clear fiber optic training. And this is all during core comps. I'm going to have Glenn, if you have a second, can you pop in and to describe to them what that fiber optic training is going to be like?
Sure. So yes, as many of you have heard, we are switching over to the GlideScope Go. It is a newer video laryngoscope device. It does have some increased capabilities beyond what we have with our current King Vision, and I think you guys will really like it. So plan is we've already trained a handful of people that are really interested in airway, and they are going to be kind of our super users, our train the trainers, and these are providers just like you guys are out on the streets that you can rely on as resources. And we're all going to kind of work together and work you through a core comp station where we focus strictly on the GlideScope Go. So this device, like I said, is going to be really helpful. It's going to provide us with a lot of extra features that we didn't have in the past. So the training is going to be helping you guys fully understand its capabilities and how to properly use it and give you some hands-on practice. And then down the road, everybody's going to have one of these kits as well as some extra blades for training that you can use with your 7 Sigma mannequins. And then, like I said, you'll have resources both throughout the county with fellow providers as well as myself and whoever else you want to talk to, Dr. Panchal, Dr. Mongi, regarding this new device.
And Glenn, how long is the training where you're at core comps?
So training for core comps is going to be an hour long. So it's actually going to be 2 stations worth. So we're trying to give you guys as much hands-on time with it as possible.
So this is a big priority for me, guys. I want to give you a device that you can support you. One of the biggest things I can tell you about the GlideScope Go is its psychomotor behavior is most similar to what you do with laryngoscope. Okay, most similar. So when we do the King and we use a channel device, that behavior, the psychomotor behavior is very different. So being able to have a consistent psychomotor behavior, and again, we supported that, like through our training that we did with Airway right here, we supported the use of the laryngoscope and that behavior, and you got to clean up your behavior and actually improve on your skills there. That just builds on what you're going to be able to do with the GlideScope Go. And that consistency is what we're looking for to allow you guys not to have learn another behavior, but you can be more consistent. I know a lot of people did really great with the Kings, which is awesome. Sorry I'm pulling it, but I think that long-term, this will be better for the overall agency. The other piece is continued difficult airway skills. So what we'll do throughout the next year or two is you'll see this mannequin come back, and we'll talk about different tools we're going to use, different approaches. We'll put you in different scenarios and challenge you a little bit about being able to do those innovations. Okay. So more than anything else, that was what I wanted to cover right now. Any questions about these concepts? I'm going to stop my share here. Any questions about these concepts and what we did with the Airway stuff? I do want to do a great shout out to Scott Gano and Glenn Keating for all their work, as well as our Airway team, who really put a lot of effort and time into the videos and all that kind of stuff to be able to put everything together. I'll be frank, I was a small part in this whole process. The team really made it happen. Any questions on this stuff? I have a feeling you feel bludgeoned by Airway. And that's okay with me. Cool. Okay, with that being said, the clinical update wise, no major clinical updates for me right now. I'm not thinking anything you can think of, Glenn, right now. I got nothing yet. Okay, so just keep in mind core comps is coming out. That's about it. And make sure you sign up for those of you who have not signed up. Oh, one more thing from clinical update side. So we reviewed the data for people actually coming to the Zoom meetings. And I want to throw a shout out to you guys. Thank you so much. We were like near 90 something ridiculous % of people actually viewing these crazy things. So yeah, so thank you for that. Thank you for your patience with that. It seems like it's actually a tool that we're using that we can get clinical information out. So we'll just keep plugging away if you guys aren't throwing tomatoes at me yet. So we'll start there. Okay, with that being said, Chief Burgess, you're up, buddy.
Hey guys, good morning. The only thing I have real quick is I just wanted to just kind of remind everybody, everybody I'm sure is aware of what happened down at St. Anne's last week. And that's just a little reminder of how we have to be extremely vigilant of these patients that we transport, and you know, what they might have on them, or, you know, things that might injure us. So, you know, just, you know, be aware of, you know, the surroundings and the what's going on with that call. And don't always assume that the scene is safe and the scene is secure and that the police have taken any weapons or all the weapons from our patients. So just be aware. That one went bad pretty quick in the hospital, and that could have went bad very quickly in the back of an ambulance as well. So just don't get complacent on the calls, and then keep your guard up, and, you know, pay attention to what's going on, and trust your instincts, I guess. If you think there's a problem, check it out. All right. That's all I have.
When's our next rescue task force training?
This weekend.
There we go.
Yeah, Brooke and one of your other docs are actually taking this one. So
nice.
Yeah, you guys, if most of you guys are probably taking that tomorrow. So t-shirts are okay for this training. Bring your vest with you. If you don't have a vest, we'll have vests there for you. The helmets will be there for you. Knee pads will be there for you. You know, there'll be plenty of water and stuff there if you want anything else to drink with that. Just, you know, stuff you're allowed to drink at work, bring that with you. Breakfast and let's see, there'll be a light breakfast tomorrow, and then lunch and dinner provided Saturday, and then Sunday will be breakfast and lunch. So your meals will be handled for you. So it's a good time. The DTU guys will be there Sunday again. They were there last Sunday, and they'll be here again. We'll also have some visitors. Like I said, we've got some docs from OSU. They're going to be incorporated into the training. And then starting with the last three that we have, there'll be people from out of state. We've got some guys coming, 4 or 5 firefighters and police officers from Cheyenne, Wyoming will be coming. And we also have, I believe there's a fire chief from Washington State somewhere that'll be coming to one of the trainings. So we'll have plenty of guests and visitors in there with us. So Eleanor, you have a question on the bags and tourniquets for the trucks. So those we're in the process of going through that. Lieutenant Jividen's working pretty hard on that. What we want to do is, as you guys go through the class, he's going to ask your feedback, what you thought about the stuff. We just actually ordered some bags that are supposed to be here today that we're going to try to get into the class tomorrow for you guys to try while you're in that class. So we'll get those outfitted today and use those in the class, but they'll be placed on the trucks once everybody's been through the class. So that'll be later this summer. We'll get those on the truck. We'll get everything purchased in there. We're just those bags will be set up a lot like what the rest of the county has, what the fire departments have, basically the same stuff in there so that everybody's on the same page. That's that whole, we're really pushing to get everybody, using the same stuff for these things. So we're working on that right now. And like I said, there'll be some bags there this time for you guys who are taking a class this weekend to demo those bags. So.
One addition to that, guys, you're going to notice that there's a little more push from our team, both operations and clinical, to really look at our standardization. I want to give a shout out to our standardization committee. They're working really hard. They've been working real hard to kind of figure out what we need and where we need things and to clean up what we're doing. And that they brought that to the clinical team. And so we're putting our heads together and make sure this all go in the right direction. So over the next year, you're going to see some changes in bags and stuff like that just to clean things up. And this is all in line with our unified protocol, which is also getting cleaned up. So for those of you who were here last week, you saw Glenn demonstrate the unified protocol. We're editing it, so it's an active process. So it's kind of an exciting time because we're actually really getting on top of a lot of these things. So you're going to have to deal with us a little bit as we do go through this process, because I think it's one of the things that we've been struggling with for a couple of years, and we decided and made a decision in the standardization committees, literally leading the effort of getting us on the right track. And so just kind of be patient with us as we go through these processes. But great. That's all ops side. That's not me. So so bringing it to me, that was great. So thank you guys for all the support on that side.
That's all I've got, guys.
Cool. I'm good too. Any other questions before we wrap up, guys? So keep in mind, COVID has a little ramp up. So make sure you stay on top of yourself about using your mask when you're out in public and things like that, so you don't get bit. I mean, I think we're well protected, but you never know. You never know. These weird things can happen. So with that being said, take care of yourselves, take care of your families, and I'll see you in 2 weeks. Thanks, guys.